Tonight's presentation, Dr. Desmond Pink is a research associate with Dr. John Lewis Laboratory, Department of Oncology, University of Alberta. So many of us that have had the opportunity to see John Lewis presentations, we've been following him for a number of years through our association with Calgary. We are fortunate to have Dr. Pink here with us. His main focus is the development of prostate cancer microparticle biomarkers. His research has identified new markers which are used in a liquid biopsy to detect and enumerate microparticles which are not only prostate cancer specific, but also indicative of disease status, normal, benign, or metastatic. So it's exciting leading edge research that they're doing. And I think from talking to Desmond earlier, he's going to be sharing what they've accomplished in the last few years, but zeroing in on one specific molecule, if you can imagine. I know I can't, and we're very fortunate to have him join us tonight, so please welcome Desmond Pink.
I've worked with Dr. Lewis for 12 years. I actually just had my 12th anniversary this week. And I started off with John looking and using chicken embryos to study and fight cancer. So basically is what we're going to talk about. We're a metastasis lab, so we study those cells that should stay in the primary tumor, how they actually migrate out, and the mechanism behind that and why that's bad. We go after treatments and ways to actually diagnose if and when this actually happens. So studies in metastasis are how chickens help fight cancer. So I do have to disclose my title has changed. We've been lucky enough to actually take this research and spin off, not one, but we've actually spun off about 3 companies right now. So one of the things that we're very cautious about, it's one thing to actually have a discovery in academia. But if you're going to take that discovery to the clinic, you have to commercialize it. And that's a very different path than what you're actually taught at the university. So we've done that. I got my own skin in the game. I'm a co-founder. There's 4 of us in this particular company. And right now I get the designation of Chief Science Officer. It's cracking already. So you'll probably all know this, but the biggest problem with prostate cancer, out of 100 men, 36% of newly diagnosed cancers and 10% of all cancers in men is prostate cancer. But out of 100 men, 16 are going to be diagnosed with prostate cancer in Canada. In reality, we're all going to get it. By the time we're 80, most of us are going to have prostate cancer. 3 of us are going to die from that. The tricky part is figuring out which 3. Which 3 of us are going to have that cancer leave the primary tumor site and become metastatic? How do we figure that out? And that's the diddliest aspect. And in North America, we're actually very fortunate. We have a great medical system. And some of you will have seen these slides before because John shows these every time that we talk. But if the cancer is still in your prostate, your chance of survival after 5 years is 100%. For metastatic cancer, that drops to less than 30 because that's the problem. We don't detect the metastasis fast enough. The tools that we have don't. PSA wasn't designed to go after metastasis. The digital rectal exam wasn't designed to go after metastasis. So we've spent the last 20, 30, 40 years looking for new tools. And what's happened is that technology is now catching up with some of the ideas that we've had in the last little while. But still, the current treatments and diagnosis tools don't prevent or cure this metastasis. So what do we talk about when we talk about metastasis? Well, metastasis is not just a cell leaving that primary tumor, right? I think when I started first, I never thought about cancer cells actually moving. But after working with John for about a week, I realized that it's a really complex mechanism, but these cells move and walk and migrate. Essentially what you're looking at in these green cells here, the first thing they have to do is they have to leave that primary tumor. So they've got to break that space and get out into the blood flow. Get out into the blood flow, they've got to migrate and negotiate their way all through the bloodstream, get to a spot that for some reason seems appealing. They need to get out of that bloodstream now to actually start to proliferate in a secondary site. And then once they get into that second site or niche, they can actually start to thrive and reproduce. But what governs all that? It's the stickiness. So imagine a slinky as it moves. You've got to have sticky parts that go, and then the back half of the cell has got to be loose so it can actually keep moving. There's got to be another part of the cell that, stick, release, stick, release, stick, release. But what controls that stickiness? That's the key, is understanding that stickiness that makes the cell able to adhere when it needs to, but also let go when it needs to move. That's the hard part. So what have we done in the past? And I'm sorry if some of these are graphic, but you guys have all been involved in prostate cancer. It's graphic. You all know this firsthand, okay? There's nothing pretty about this. The tools we've used in the past have basically given us a snapshot. So typically what we do is we'll give an animal cancer, we'll wait a while, we might give it a treatment, but then we'd have to go in and kill the mouse or the rat, open it up, and see what happened. But we all know that cancer doesn't work that way. There may be a part of the tumor that's working in one way, there may be another part of the tumor that works in a different way. But if you take a snapshot, you don't see what's going on. It's all about context. So John has shown this a bunch of ways. So looking at this picture, who has seen this picture before? So this was taken during when Vancouver was in the playoffs. Excuse me. But the couple that's on the ground, you have a couple of different scenarios. Is it a good Samaritan that helps a woman that's fallen during a riot? Is a rioter basically had an opportunity and he's stealing a kiss from an injured woman? Riot police are defending a couple's right to public displays of affection. The fourth one, at least somebody from Vancouver can score on the road. But this is just like what we do in science. You get this snapshot, but you don't know what happened beforehand that leads up to this particular scenario. I'm going to play. It's not going to play. It played when we checked it. So essentially what's happened is that during this, there's a crowd that actually runs through and they knock the woman over, and the gentleman is actually consoling her. And as they're knocking them over, the riot police actually come up thinking that these are rioters and he's actually protecting her from the riot police. So that's the context. So how can we go after that same sort of idea in science? And this is where eggs come in. And I will tell you, 12 years ago when I started with John, the first thing he did was have me sit down and crack, I think it was 4 dozen eggs. And that's how I started my job with him 12 years ago. And this is what we did. We take fertilized eggs, we crack them open, we literally put them into a dish not much bigger than this. So the yolk, after 3 or 4 days, starts to grow. And what you get is this platform. And what's nice about this is that there's a membrane on top. And because the chick doesn't have a fully developed immune system, we can take the cancer cells that we have in the lab and put on top of that membrane, and they grow, and they can grow into tumors. So we now have a way that we can actually take a tumor, put it on this little membrane. But what's really nice about it is this membrane is actually, you can see through it. You can see all the blood vessels. What it allows us to do is we can actually have, it might be hard to see this, but we've developed stains that we've taken fluorescent proteins from jellyfish, and we can inject here, so we can actually see these vessels. And we actually have green fluorescent proteins from jellyfish that we put into the cancer cells. So now we have a way to actually see the veins, or the vessels, and the protein, and the cancer cells. The scary thing is, This picture is right after we inject that. So we can just inject those right into that membrane. 24 hours later, those cancer cells have secreted factors that can actually attract new blood vessels to grow. Because the cancer cells need nutrients from your blood vessels to actually thrive. And after 24 hours, they've actually got a whole ecosystem, if you will, of nutrient delivery. This was one of the first things that really impacted me. You could actually see this. I can actually get a tumor to grow almost as big as my finger from cells that would cover less than a tenth of the top of a pin in 7 days. It's truly remarkable. So how do we do it? Well, we have our little chick there. So we grow this, and it's called an ex ovo system, so out of the egg. So we developed this little platform. We put the whey boat in here, and there's our little chick after it's grown for a while. And the tumor's right here. We have it covered. Goes down. We actually put a little piece of glass on the cover. That goes down. Put it on top of the chick. If you want to see these close up, I can show you afterwards. It's one of the coolest things I've ever been a part of. But what it does is that little glass cover goes down and it sits on that membrane, and it's sticky, but that immobilizes the tumor so you don't get any movement because the chick is alive. And we can actually image tumor growth and development, how treatments work, and how they sort of move around over 48 hours or 2 days or 3 or 4 days. And we do this in a pretty big microscope that's sort of environmentally controlled because you have to keep the chick warm and humidified. So this is what we started to see in the early days. So what you see right here is a 4 millimeter tumor growing over 4 days. And you can literally see this grow. Now we've jacked up the intensity of the image there so you can actually see it from afar. But what you made with the lighting, what you can see here is we can actually take a block from over here, and these little green dots you see moving are the cells that have moved away from the primary tumor. They've gone into the blood vessel. And I think this one you can actually see they go to the blood vessel and they go in and they go to somewhere else. That's metastasis right there. This right here would be after this guy leaves, they go to a second site and they thrive and they start what's called a secondary niche or metastatic niche. So that was early days. Since then, we've gotten a bit better. So this would be a new set of cancer cells. So as you see, just the green, there's no context. Well, now we've been able to actually inject a dye into the blood vessels. And now we can sort of see the blood vessels. So that gives us a bit more context. Now we can also inject a sugar residue that gets taken up by the cells in the blood vessels. And it stays in there for a couple of days. Because you want to be able to see these, not kill the chick with the drugs or the dyes, so that you can actually have context. Put them together, and now you start to get the context. So you can now look at that snapshot and translate it over time to see how things change. Taking that one step further, we take this tumor, similar as what we had in the last slide, but now we can zoom in. So now we can actually look at the metastatic front and actually look at the membrane on top, a big blood vessel, and actually see how the cancer cells actually work in conjunction with blood vessels here, but also major blood vessels. And since we've actually started this, we've actually now figured out that there's a whole layer of collagen that goes around all of these blood vessels, and some of the cells actually will follow the collagen fibers. So as the collagen actually orients itself, they'll follow that, and that's one of the ways that they may be able to move. So this is more pictures, but what these actually enable us to do is, if we have a potential treatment, we can actually say, this is what it looks like before we add the treatment, this is what it looks like during, and over time. Because some treatments will work right at the beginning, and it just peters off. Some treatments will work very slow and go long. Others may go in this sort of trajectory. But if you took that snapshot in the middle, they all look the same. Right? So you have to be wary of how all of these work together. That way you can actually make more inform decisions about what happens at what time scenarios. So, sorry, I'm rushing. What's the difference between the cells that spread and the cells that don't? So what factors sort of encourage a cancer cell to move out of that primary tumor? Is there a magical switch? Is it one factor? Is it many factors? Does one cell leave at a time, or do many cells leave? These are questions that get asked all the time. So we're looking for that magic target. That's what we're saying here. It's a bummer of a birthmark, because that's the magic bullet that we're going after all the time. So just as we had in that slide, how do we figure this out? So we always sort of classify this as these are the cells that are less metastatic, okay? Versus these cells that have already moved away, these are the more highly metastatic cells. So is there a way that we can actually go after one without tagging the others? Because of course they're both metastatic, so one is less than the other. So we can take those cells that are less metastatic, go right for the inside of the tumor, and actually immunize a mouse with these. We can then treat them so that the mouse can then handle cells that are more, we can tolerize the immune system so the mouse won't reject them. We can then immunize the mouse with a high metastatic variant and then collect the antibodies. So now we have a way to actually generate antibodies from both high and low metastatic variants. So we want to be able to target just those highly metastatic ones. And that's what we were able to do. So John was able to work with this protein, I think about 15 or 16 years ago. So this was the start of it. And we basically identified a protein called CD151 that works with the sticky proteins on the cell. So it's not the sticky protein, but it works with the sticky proteins, or works in conjunction with them. So how did we know this? Well, once we figured out that that antibody worked, what we did is we went in and we treated the chicks with those highly metastatic cells, but then we actually added an antibody. And when we added the antibody, we blocked metastasis in the chick almost 100%. So it's a chicken. So we did it in mice. We did it in Edmonton, we did it in London, Ontario, and we did it in Nashville in the US. It blocked the metastasis in the mice. So we have a real target. This works. But we have a great imaging system. So what does this look like? So on day one, when we do the injection of the cells, we've just sort of taken a picture of a single cell. So the red would be the blood vessels, the green would be the cells. You can sort of see they're one. After a few days, these are going to reproduce to get metastasis. What you see here is in the control, they've got sort of no antibody or antibody control. The cells have reproduced, but they're also spreading. So they're following that metastatic mode. They're spreading out and they're leaving. The cells that have the antibody, they're still alive, but they're compact. Are they dead? No, they're still alive. They're still reproducing. You're still getting a tumor there. So we haven't killed it, but we've actually blocked it from moving. So how do we know that? Well, we're able to take these movies and we're able to track individual cells. So that's what we're doing here. In the control, we can actually put a marker on these and follow the movement of the cell over about, 200 steps or 300 steps over a number of hours. And you can see how far they go. Sometimes they actually will just, go, but then other times we have what we call productive movement, where they move away from that primary tumor. And that's the scary part. Put in the antibody, and they stop. But what's going on? So what we're going to show here, yes. Imagine if you had, because I always think about what my neighbor had growing up. He had this little tiny dog, it's like a little beagle, and he had it on a rope, chained on, but it was an elastic rope. This little dog would run, and snap back. And that's exactly what these guys do. The control can move away, but it's like the tail or the back end of the cell is stuck. So remember I talked about that sticky part, that the cell's got to be able to stick and release, stick and release? It can't release. So that's really cool. Can we use this? So we figured out that this protein is actually active and it's free from the sticky parts of the integrins, we call them. Can we use this as a test for diagnosis or predictive of metastasis? So what we did was, I'll backtrack a bit. We initially thought we could use that as a therapeutic. Turns out that protein sticks to platelets and it basically gums up your entire blood system. So as a treatment, not so good. But we could use it as a marker. So first we had to confirm that it actually is predictive of metastasis in cancer. So we did that using 138 prostate cancer surgery patients. What we were able to show is that if this particular protein, this sort of free CD151 that works with the sticky proteins, if that's around, it can actually influence how fast children relapse, but also influence your rate of metastasis. So if the protein is there, the incidence of metastasis goes up and men die earlier. If it's not there, men tend to live a lot longer. And you can go from, I think the halfway was 3.7 versus 12.7. It's almost 4 times the difference. So this basically told us that this is a real marker. But how can we use it? We got to figure out some way to actually use this now. And we sort of banged around on this idea for a while. And that's just a summary of what I said. How do we actually use it? So we said, okay, we'll use it as our benchmark. We'll use the activity and the function and the way that this cell makes these cells move around, or this protein makes cells move around, as our metastatic benchmark. So we took the chick embryo again. So this would be our control, and then this would be when the protein is removed. So what we did is we actually took all of the genes in your body and we knocked them out one at a time. And you can do this in a variety of screens. And we went through thousands of these chicken embryos. And basically what we did is we would grow these colonies on the chicken embryos. We would look for those little tiny compact colonies and we'd cut them out. Then we would separate the cells and we'd go back and we'd grow those cells up and proliferate them, put them back on the chicken to make sure we actually add a clean target. Because there's no point if you have a big mixture of pluses and minuses. You need to have a clean plus or a clean minus. And we were able to come up with 27 clones. Out of about 10,000 potential hits, we got 27. This took about 4 years to do. This one graph is the culmination of 4 years of work right there. But what it gave us were these 27 hits. But more importantly, these 11 new biomarkers of diagnostic and therapeutic interest. And we've already started tracking these down. So just to confirm, once we add these targets, because we isolated the cells and we did a genetic identification, we basically reverse engineered the targets. We had to go back and then confirm that indeed these targets that we've identified worked. So we did it in the chick embryo. So you basically have your control where we've not knocked out anything, and then 3 targets. And it's not all or none. This one here, we can actually, we got a pretty good response. We knocked this particular marker out with metastasis. The cells don't spread. So this is your primary tumor, and those cells are leaving. This one's about a medium, and in this one, there's probably more than one marker involved in how that protein works to block metastasis. So we're on the right path. We keep going. We did it in chicks. We did it in mice. In mice, we're closer to the human situation. We were able to actually block metastasis by 99% with a variety of these markers. So it was to the point where one of these markers, we've tracked it down in a subsequent study, and we melted the tumor so fast it actually cause a toxic response in the animal. So we're on the right track, but that's still going to take a number of years to follow up. We confirmed it in other situations, not just prostate cancer, but the markers that we've looked at, they're involved in melanoma, prostate, head and neck, lung, ovary, and colon. So it's not just a prostate cancer marker, it's a true metastasis marker. So we're actually going after what are those control mechanisms that make those cancer cells move. So I'm going to get to the part now. So that a lot of that is the therapeutic side of it. I'm more involved with the diagnostic side. So if we have this switch that tells cells move or don't move, or they're involved in the controlling how that switch is made, can we detect aggressive prostate cancer? So, of course, screening involves monitoring your PSA and a digital rectal exam. The PSA test was never designed to be a screening test, but it's one of the best things with that has come along. But again, it's only 15 to 25% specific. So while the PSA test can actually detect very, very small amounts of PSA, which is exactly what it was designed to do, as a way to decide you have cancer or not, it doesn't work so well. You have to have a biopsy for diagnosis. And this is what we're trying to help. So our mandate when we came here 7 years ago was, how do we help the urologists make better decisions about who goes for biopsy? That's been our mandate for the diagnostics team. Because at the end of the day, more than 3/4 of us are overtreated. And getting a biopsy is not trivial. I don't need to tell most of you guys that. More than 1 million biopsies are done every year in the US. I think about 2,000 are done in Edmonton every year, maybe more, and similar numbers here in Calgary. It's a lot of men that are getting biopsies. Some men get sepsis after they've had the biopsy. It is a very invasive procedure. You're basically perforating your large intestine to actually get after the prostate. That's problematic. And because antibiotic resistance is on the rise, this incidence of sepsis is actually not trivial. It's not something that we can just throw antibiotics at now and it's going to cure it right away. There are significant problems. So this big study was published in 2015. And there's no surprise here. Men that have worse Gleason scores have worse outcomes. That makes sense. But how do we identify those men that actually have those Gleason scores without doing the biopsy? So the FDA has released one test that actually looks at circulating tumor cells. And essentially you take one tube of blood, and getting a blood draw is way easier than a biopsy. But you have to think about it. The circulating tumor cells are rare. Only about 1 in a billion are actually ever going to survive. That's a pretty low incidence. So we've got to be able to find that 1 in a billion. That's literally the needle in the haystack. So what they've sort of set the bar at as being aggressive is that you have to have more than 4 of these cells in a tube of blood. So if you look at the data that these guys came up with, they took 100 men that actually had confirmed bone metastasis. These are metastatic cancers. 43% of those men actually had less than 2 CTCs in that tube of blood. Almost 20% at 0. So if the benchmark is more than 4, but almost half have less than 2, it's not a very good test. So why doesn't it work? We'll get to that. But what we noticed when we actually went in and looked at that paper in a bit more detail is that there was a lot of bits of the cells going around this person's bloodstream. So it wasn't an intact circulating cell, but there were bits and pieces of it. Could we use that as a way to look at stuff? So sort of gives you in a simplified version. In one tube, you might have 100 circulating tumor cells, but you might have 10,000 of these little bits. So if we could have some way to look at those little bits, we have a pretty good chance of finding a signature that you have aggressive disease than just looking at 100. So what are these little bits? We call them extracellular vesicles. And they're literally just little bits of the cell. They could come from the tumor cells that have exploded into your bloodstream. Sometimes the tumor cells spit them out normally, but that's what we're trying to measure. So imagine taking a picture of a house and then take a picture of one of the stones on the walkway going up to the house. That's sort of the scale, if you want. So the snapshot, you got to have a good camera to go after it. So that's what we've been developing. We've been developing the camera to go after it. And sort of give you an idea as to the scale reference, here's your cancer cell. Here are the platelets in your body. These are the size of the particles that we're trying to actually look at. So they're really, really small. How do we do it? Well, essentially we take this blood sample, we shoot it through a tube of water, and a laser hits it, and light scatters. We're actually able to capture the light that comes off it and actually take a diagnosis, and we're looking for patterns. So this is actually, because we spun off the company, we've trained and developed the test. This is actually now being used at Dynalife in Edmonton. And we can look at a whole bunch of stuff. You can see the plasma, the serum, so urine. We're working these tests up in different fluids. So, because one of the big problems is, if I've got to go in, if my doctor says, or my wife tells me, you got to go in and get a biopsy to see if you have prostate cancer, that's pretty scary. But if they say, go get a blood test, I'm a lot more able to go after a blood test. That's one of the other parts of developing a test. You've got to develop something that men are going to do. If you've got to go in and get a biopsy, nobody wants to do it. But you'll force yourself to go get stuck with the needle way, way more. So what this is part of, this is, we've actually had to figure out, how do we analyze all this stuff? What are the right ways? What are the mistakes? This is brand new technology. But can we actually find, number one, can we find particles that come from the prostate? So here we can actually identify, using a marker specific to the prostate, only those particles that come from the prostate, because you're going to get particles from every single cell in your body. Then you need to have a marker for the disease. So is it cancer or is it not cancer? And then another marker to say, is it benign, normal, or aggressive? So it's a multitude of markers. And we've got that part covered. The other part now, this is a new technology. So now my job is to actually go in and convince the FDA that the technology is sound, the test is sound, because I want to be able to go to you and say, take my test, trust the results. So I've got to show that, number one, the machine works the way that I think it works, the test works the way that it works, it's sensitive, and it's specific. So it's got to be sensitive enough to find a cancer, an aggressive cancer particle, so that I don't miss anybody that has aggressive cancer. It's got to be reproducible so that when I look at all of my biomarkers, I should get the same data if I run it hundreds of times. If I run the same sample hundreds of times, I should get the same answer. If I take a negative sample and put in some positive sample, I should be able to tell you I put in 20% positive. I should be able to see that. And I can. The other part of it is the best before date. So it was one of these things, and as we develop a test in an academic lab, we don't think about it because we're there on the bench, we take our sample, we put it in our machine, and we run it. But the reality of it is, if you go to the PCC test, you go to the PCC, get your blood drawn, well, that blood tube is going to sit in a container. Then it's got to travel to the diagnostic center. The diagnostic team, and we'll put it this way, you could be the first pickup, you could be the last pickup. So if your blood is drawn at 8 a.m. in the morning, it may not get looked at by the diagnostic team until 6 p.m. That's reality. So you have to test whether or not the sample is still valid after 10, 12 hours. 24 hours, 72 hours. Seems like it's trivial, but the logistics of doing that are truly a nightmare. We did this for 4 tubes, a multitude of temperatures. We did it at -35 in the middle of last winter, put them in containers. We tracked all the different temperature changes. Because if your blood sample freezes, it might not be any good. This summer, we tracked it when I went to +35 on that 1 or 2 days. But this graph, series of graphs right here, is about 8,000 to 10,000 runs on our equipment. It's almost 2.5 million data points just to say it was stable for 2 days. So we're actually extending that now. We're just starting to actually push that past 2 days to go up to a week. So now we got to look at how do these little bits and pieces of cells tell us about the disease status? Can we actually predict disease? So these are 2 markers that we've released. These over here, we've got patent protection on them. This one is used in about 30 clinical trials as a known indicator of prostate cancer disease. But in our hands, when we look at cancer and no cancer, it gave exactly the same results. This other one, which we had shown is a predictive marker of benign versus cancer, was actually pretty good. But just look at the means. I mean, it's just a little bit different. We got to be able to say, this is normal, this is disease, not this is normal and this is disease. So how do we do that? And this is where one of our team members, he told me one day he liked to code. So I said, well, Rob, what do you mean you code? He said, well, I wrote a video game. So we took Rob off the bench and we threw him into machine learning. And you've heard of like Google's DeepMind project that's in Edmonton. So we work with those guys as well. That's who we go to if we have questions. So what Rob was able to do was actually able to integrate a computer algorithm to look at all of these little bits and pieces. Because every single sample that we run, we analyze anywhere from 1 million to 5 million bits of these cells. But on each one of these bits, we probably get between 8 and 15 additional pieces of information. So the size of that data, not one of us is going to be able to actually sit down and say, here's a pattern, right? It's impossible. So what Rob has been able to do is take out and look at all of the different types of machine learning. And we're not just going in and pushing a button. He's actually writing the code to understand how all of this works. And he's actually able now to provide machine learned signatures. And this is just with 2 parameters. This is not with all of our biomarkers. This is just a small example. We're actually able to show signatures from +1 up to +5 Gleason score. And that gives us a way, even visually, to actually say that works. And of course, that's only part of the story. That's just the flow. Or that's just our test. What he's also doing, this is what was available about 3 years ago in terms of how machine learning is going, right? So this is a field that's exploding. If you want an example of how machine learning affects your everyday life, how many of us have been online and we've looked at a product and then all of a sudden we get advertisements for that same product? That's machine learning. It's gauging what you in this district is looking at, and then it makes patterns of what everybody is looking at. And then it starts to inundate us with like 50,000 advertisements. But Rob is taking all of those ideas and it's basically saying, if I get this, these are the potential questions I can ask. These are then the potential answers I get. And he forms patterns. He looks at the patterns for, say, 500 patients that are normal or not disease, 500 patients that have Gleason 1, Gleason 2, and then we get patterns for all of the different ways that the disease can change. And that's how we get our overall algorithm. So to sort of put that into a simple slide, we get these particles from a simple blood test. It's a single tube of blood. Basically what we're trying to do is, it'll be a reflex. So if you go in and get your PSA test done, and your PSA comes back as suspicious, that tube will actually come to us, and we'll run our test called the Clarity DX. prostate. So we use the same samples. You don't even have to go back and get a second blood test. We get all the different particles. We get a printout from our flow cytometry is what we're using. We then take Rob's machine learning, and that gives us a fingerprint. So now we got to take that fingerprint and give it to the physician so that the physician can show you and help you make a better decision. Because these are not for men that have PSA that's going to be 30, 40, 50. Those gentlemen are going to go and have a biopsy. It's for those of us that will have a PSA 3 to 10, that we're in that gray zone. But it takes the flow cytometry data, so our test data, but it also takes all of your clinical data. So your age, your PSA, if you've had multiple PSAs, if you've had more than one biopsy. It takes your digital rectal exam, ethnicity, age, all the factors that you would normally give to the doctor to make that decision. We factor all of that in. That gives us a risk score. What's your risk? That basically means you can make a much more informed decision about your next stage of treatment. Excuse me. So how did this work? So we did that with a cohort of 377, 400 patients, and this is patients from the early AppCarry studies. What it meant is that we could actually have an accuracy of about 83% of telling which men had aggressive prostate cancer. So what does that mean? We break it down a bit more. 95% sensitivity so that we don't miss anybody. But PSA was 17% specific. So 17 out of 100 men we could actually say with our PSA test. But when we put in the Clarity DX, we can bump it up to 56. So that means instead of 17% of men knowing they shouldn't go for a biopsy, 56 men now have that same answer. That's a 40% increase, which is pretty good. If you can tell 40 more men, you can wait. That's pretty important. So how did we figure this is going to work into a treatment model? We're going to follow, pretty much the standard of care we have right now. The patients that are at risk, take the PSA test. Your PSA is greater than 3, less than 10. If it's in that area, the sample then comes to us. We run the Clarity DX. If you're at a high risk, you get the biopsy done, because that's still the main way to diagnose if you have cancer. If you have low risk, you continue monitoring. And of course, if your PSA is less than 3, you follow the standard of care as it is today. So how are we putting that into treatment? Well, we spun off the company, we've gotten some investment, but we've started a clinical trial as of the early part of the summer, where we're taking patient samples as we've done in the past, but now we're actually analyzing them fresh as you would your blood biopsy, if you will, your PSA test. We're hoping to have about 500 patients per year from both Edmonton and Calgary. We're also working with the Motorcycle Ride for Dad group in the Yukon. We're getting patients from there. So that's going to be the real test of our logistics of shipping, because we're going to ship those samples down in the middle of winter, which we're working on that. But we also have to get samples from the US. So we've literally just identified our site in the last 2 weeks, because of course, if you're going to the FDA, which we've done, you have to balance for the ethnicity. So to get our numbers for the African Americans and Latinos, we have to go to the US. So that's another 250 patients. So we're hoping to have about 1,400 patients in our training phase, and then another 1,500 in our validation phase. So that basically means the same sample you get taken today is going to get shipped to Dynalife in downtown Edmonton. Our machines will run it. The technologists that we've trained are there doing it. And we're still figuring out the Yukon and the US. But it'll be the same idea. The samples will be taken, they'll be shipped overnight, and we'll get them within a day. Processing right now, we're confident that they're stable for a minimum of 48 hours, but we're also doing an extended stability right now to actually push that. The hard part, the truly, truly hard part, is that we're doing this under a regulatory environment. So we're not just doing this willy-nilly in the lab. Every single piece of data is time stamped and initialed so that the FDA can come in and audit us and see. We're doing this just like a standard drug trial. If you're bringing a new drug to the clinic, we're doing it in the same fashion. And that has been an extensive learning experience. But it's good. I mean, that's the ultimate goal of actually taking that, the phrase that we hear from bench to bedside. You have to have that mark. You need to have a regulatory team. That's the most hated person in the lab because Rebecca is doing the hardest job because none of us want to fill out paperwork all day. Give an example. Every single sample that's run in our clinic, there are between 25 and 45 pages of signatures and transcripts that go with it. And if something goes wrong, it's an investigation until we find out exactly why that went wrong. So with that, I think I'm just under time. There's a lot of us we've been working on this for between 12 and 15 years. There's been a lot of people. We took this picture for the Plan for Dad this year. So this is drug delivery, Nanostics. Of course, this is roommate from that Calgary. Nanostics, that's our diagnostic team, is Nanostics. Computer programmer with Nanostics. And we're not just doing this too. I had a summer student. So this is a young girl from just south of Killam, I think. And we got her as a WISA student from high school. So we're not just doing this, we're also training the next group to come in to start thinking extremely critically about what they're doing. So this will be my lateral in the drug delivery team, Arun. Bridget's with us. Katya is the lab manager for John's academic lab. These guys, drug delivery. This is all the Nanostics team. So there's a big group of us. We've gone from 4 people 2 years ago to 14 full-time staff and a lot of regulatory consultants. It's the regulatory part is extremely tough, but without the samples from the Alberta Prostate Cancer Research Initiative that John started 7 years ago, which basically means if you guys have gone to the clinic and you've been asked to participate in a study, chances are I've run your blood. There's actually a really good chance that I've actually run your blood. I would never know that it was your blood. The Alberta Cancer Foundation, Alberta Innovates, the bird dogs who helped start the funding for all this have been critical. The motorcycle ride for Dad. If you guys have seen them going through, these are a bunch of guys that go out and they raise anywhere from $50,000, $20,000 to $120,000, $50,000 a year, and it goes right into into a lab. There is extremely little money that goes to admin. It literally comes in. We also work well with Movember. We're actually, the Alberta Prostate Cancer Initiative is one of the leaders in understanding how, I think you were talking about filling out quality of life stuff. We've actually put in more quality of life questionnaires and data than anybody else in the world. So basically what you tell us is now going worldwide, and that helps how men are affected by cancer, and we can better understand how they're affected by cancer. Because it's not just the disease, it's also mental health. And of course we work with DynaLife, and so to give you an example, the two technologists that I work with, one has 25 years of experience at DynaLife, the other one has 35. So we're getting a massive amount of knowledge transfer that you're not going to get anywhere else. And of course, Prostate Cancer Canada. So with that, I'll stop. I think I'm 1 minute over.
Questions?
There's a lot of heavy tech there.
Hi, Desmond. I've got 2 thoughts that I'd like you to think about and maybe respond to relative to your tests here.
Okay.
I'm a warrior, and we've got probably a third of this group are warriors. And if you ask them, probably every one of them would have wished that they had been diagnosed earlier. And so the practical issue, I think, is the diagnostic process being implemented at the family doctor level as opposed to at the urologist, because your entire sample database
Is from the urologist.
is based on a referral of suspicion.
So we've talked about that.
Yeah.
So that comes down to the education process. To actually get this, the first thing we have to make sure the test works. And that's only by running these 3,000 men, 2,800 to 3,000 men. After that, we've already started a plan for the education process. How do we actually educate each of the family doctors? It's one of these things that we talked about when we developed this test. You can have something that's going to be truly disruptive. But if something is truly disruptive, it's hard to do a culture shift. Because doctors have this, you do what works. And sometimes it's really hard to shift that because you don't want to compromise the welfare of your patient. So the education, that's where we work with Eric and Brian from the PCC. We work with Adrian at NOC. Where these are the leaders here in Alberta. And on our board, we've got international leaders. So it gets translated to the urologist, and once it gets translated there, then it becomes the education to further out into the Alberta Health. Is it Alberta Health Service now? Yes. Still AHS. So that education process is harder.
You're trying to financially justify your test on the basis of minimizing risk associated with biopsy. I have a feeling that...
Well, risk associated with biopsy, but also to identify them in the prostate, progressive prostate cancer first, so it's twofold.
Okay, I'll accept that, yeah. I'm just thinking that we're missing a real driver, and that is the population that is actually seeing the family doctor. And
Yeah.
the earlier one can detect the potential for cancer, prostate cancer, whether it's mobile or not,
Yeah.
we can then have a greater likelihood of not having, being able to apply surgery at an earlier stage so that there's less risk of escape from the gland.
So my personal take on that is that it's a culture shift.
Well, no question.
In the same sense that my father's generation would never talk about the mental health of anyone within the family, outside the family. Whereas today we talk about that. You go to any of the PCC stuff, it talks about the mental health. Any cancer person, man or woman, it's amazing that the fortitude is there to actually survive the mental challenges, let alone the cancer. 20 years ago, I don't think we talked about that. So now we're talking about educating the family doctors that could be, and I mean, I grew up in a village of 1,500 people. I was diagnosed with rare gluten stuff, or gluten disease, just because the doctor went on holiday and the resident was from Latin America. So I completely understand what you're saying. It's a truly educational problem. That's what it is. How do we educate? I don't know. But we have started on that. We have asked that question. And that's something that I think working with November and the Alberta Cancer Foundation will help. But that's going to be a bigger problem.
Just another question, and it's more the tail end of the life of warriors, if you will. I've actually been subjected to 5 different drugs. And so in a serial fashion.
Yep.
And I've become resistant to those drugs in sequence. And I have the impression that the disease is different
So
at each stage.
yes and no.
Have you looked at it
So
from that perspective?
yes. So cancers, I'll do this in two steps. So a tumor is not one type of cancer cell. It's a huge mixed bag of cancer cells. And typically, and you probably know this story, you do the first drug, and that seems to work. What it does, it goes in and it destroys all of those cancer cells that are prone to the activity of that drug. You don't get the rest of them. But remember, they're cancer cells, they're going to proliferate and reproduce at a much higher rate than normal. So the ones that aren't that are resistant now become the most predominant tumor cell in your tumor. So you keep going through those iterative phases. You've killed the first batch, and it's a wave. You're never going to get all of them if you're dealing with a mixed bag of resistances. To put that on a different way, we all see these commercials about taking probiotic bacteria for your in the yogurts. You got to eat that every single day. You can't just take one. You've got to keep eating it, because what you're doing is you're populating your gut with these probiotic bacteria, and you're just overwhelming the rest of them to make one population thrive. It's the same sort of idea. The other part is that we know that these cells also change. We talked about a motility switch with this CD151. As a cell is in the primary tumor, there are a series of biomarkers. As that cell changes and becomes more metastatic, the proteins that are on its surface or causing it to work the way it works, they change. So you may have an epithelial marker, so the marker that's on the outside, say, I'm this type of cell. Well, as that cell becomes metastatic, those sort of markers that say, I'm this, decrease. And then the other sort of markers, it's almost like you switch your face, and I'm now this. So what we sort of look at the beginning of the disease and say, this is aggressive cancer, may be different at the end. So it's not always you get one biomarker and it goes up. You could get a biomarker that goes like this as your disease progresses. So it's never, I never look at it as a straight line. It's always a pattern. And sometimes that pattern is, it could be like this, or it could be like this. And it's not trivial. And finding out those patterns is where the machine learning comes in. I don't know if that answers your question. It's something that I think as a field we're struggling with. Because we want it to be, we desperately want it to be straight. But it's not going to be.
Desmond, to come to your family doctor scenario and say that there's education there required, is there any way we can push that?
Talk about it. I go out to the motorcycle ride for Dad at least once or twice a year. And this year there were 300 bikers. Last year there were 500 bikers. And I got up and said, I work for Nanostics. You guys give donations. I work in John Lewis's lab. I'm the guy that spends the money. You have questions. This is what we've done with your money. That sort of gets it. If someone says, would you want to come and speak here or there? I go out, I speak. I've literally dropped the puck in Didsbury.
So what should we be saying to our family doctors then?
Go find out about it. You know, invite them to the app carry meeting. Give them a link to the website.
Yeah.
Get them to ask questions to the urologist. How do we find out about this? I mean, I think Alberta is unique. We've got the man van here.
Yeah.
I've never seen that anywhere else. I mean, that's brilliant. It's getting that idea out there that we can do more, not just as individuals, but as a group. And we struggled with that 7 years ago. How did we get Edmonton and Calgary together? And we literally locked them in a room. And we started a conversation, and that's translated. We started off with 50 people, we're now 300 people strong in our initiative. It's slow, but it gets there. Imagine November was a group of guys having a beer, right? And look at that today. So it gets out there.
Good. Are we done? That's it?
Thank you.
Okay, Desmond, thank you so much for your time tonight.
Oh, thank you
Just a
guys for having
small
me.
token of our appreciation.
I appreciate that. Yeah, just take a look at that.
Well, we're thrilled to have you.